Thank you. So I'm joined by three very resourceful panelists. We are going to take us through cancer survivorship. And without wasting a lot of time, I'd like to call in Dr. Joy Frida. I hope you can all see her screen to start us off. Karibu, Dr. Joy Frida.
Okay, thank you, Solomon. Good afternoon, everyone. Thank you for joining us. My name is Dr. Joy Frida Chepchumba. I work with the Ministry of Health under the National Cancer Control Program. I'm the officer in charge of treatment, palliative care, and survivorship pillar at the program. And I'll take you through the policy perspectives on cancer survivorship in Kenya. So, the National Cancer Survivors Day, which is celebrated on the first Sunday of June, is a day to recognize cancer survivors, to bring attention to the ongoing challenges cancer survivors face, and to celebrate life. So, as you're aware, cancer is one of the major NCDs, which cause over 60% of the annual global mortality, 10 million annual cancer cases, with 75% occurring in low and middle income countries. In Kenya, it's the third leading cause of death, and the burden has been rising with a projected rise to 58,000 new cases by 2028. And the main challenge here is late presentation, poor access, and high cost of diagnosis and treatment. So this is just a chart showing the incidence. And the interesting thing is that this picture has not changed for a while. I think before we continue, Nelson, could we do the quick poll? There was a poll, launch the poll for just 3 minutes, then I can continue. Nelson. Okay. I don't know why Nelson is not hearing us. Nelson, are you able to hear us? Okay, then let's proceed in the interest of time. Then maybe the poll can be shared later on. Okay, so I think in terms of incidence, this picture has not changed in recent years. Breast is the leading cancer type in our setting. Then cancer of the cervix, then prostate cancer, and esophageal cancer. And you can see in 2022, we had over 44,000 cancer cases. In terms of mortality, cancer of the cervix is the leading with over 3,000 deaths every year, followed by breast with around 3,000 again, and esophageal cancer around 3,000, and colorectal. Prostate is number 5 in terms of mortality. So in terms of the global policies, the following are some of the global policies that as a ministry, we are aligning ourselves to. First, we have the global strategy to accelerate the elimination of cervical cancer. And this was launched in 2020. As you can see, cervical cancer is the leading cause of death in terms of cancers. And in this, the strategy would like that 90% of girls before the age of 15 to be fully vaccinated against HPV, 70% of eligible women to be screened by the age of 45 years, and 90% of women with precancerous lesions or invasive cervical cancer to receive treatment. So this is the 90-70-90 cervical cancer targets that we have. As I mentioned, it's the second most common cancer in women, and it's the leading cause of cancer mortality. 5,000 new cases, 3398 deaths, and HPV is the primary cause, and 70% is caused by HPV 16 and 18. So the lifetime risk for HPV infection among sexually active women, that is any woman basically, is 50 to 70%. By age 50, at least 80% of women will have acquired this HPV infection. But fortunately, over 80% of these HPV infections are transient, they're asymptomatic, and they resolve spontaneously in 2 to 3 years due to the natural cell-mediated immunity. Of the 20% of the infection that persist, this is the one that the viral gene is incorporated into the DNA of the cervical cells, stimulating abnormal cell division. So the risk factors for cervical cancer include early initiation of sexual intercourse, having multiple sexual partners, having a sexual partner with multiple sexual partners, co-infection with other sexually transmitted infections such as chlamydia, herpes. Multiparity is also one of the risk factors, and immunosuppression due to HIV infection and tobacco use. And this is why for immunosuppression, this is why you see we are really keen on cervical cancer screening among the HIV positive population. So who should be screened for cervical cancer and when? So basically, any woman who has ever had sexual intercourse is eligible for cervical cancer screening. And the target population for screening is 25 to 49 years. Women aged 50 to 65 are still at risk and can therefore receive screening every 5 years. And the screening interval is 5 years among the HIV negative women. But for HIV positive, this screened every year. So the screening method that is recommended is the HPV testing method, but sometimes that is not possible. So we also use the visual inspection with acetic acid or Lugol's iodine, and I believe most of us here have access to this. Pap smear is recommended in the following situations: for women who are not eligible for Viavili, and as a primary test in women under 30 years of age, and as a co-test with HPV in HIV positive women where resources are available, because it can be an expensive test. So the next global policy that we're implementing is the Global Breast Cancer Initiative. This was launched in the year 2021. And it's the goal of this initiative is to avert 2.5 million deaths by 2040 through these 3 pillars. The first pillar is health promotion by early detection. So this one, we want to increase the public education, public awareness on the signs and symptoms, on the importance of early detection and treatment. The next pillar is on timely diagnosis. So the public now is aware. The next thing now is the healthcare workers. How quickly can you identify these signs and symptoms in your clients, in your women, and when do you start up the diagnosis? And the third pillar is comprehensive breast cancer management. And the goals here is 60% of the patients should be at an early stage. They should receive a diagnosis by 60 days, and 80% of the patients should complete treatment. So breast cancer is the most common type of cancer in Kenya. It's the leading cause of cancer deaths overall. And every day, sadly, 7 women die as a result of breast cancer. And it occurs at a very young age, 35 to 50 years in Kenya, compared to the Western countries. And 70% of these patients are diagnosed late. And the main reason we've noticed here is there's the poor awareness of the general population on the signs and symptoms, on when they should seek out medical attention. But we've also realized there's also a gap in our medical team. They are not aware of the signs and symptoms that they should suspect cancer. So most patients spend a lot of time in the health system, but they're not being referred to a further cancer diagnosis. They're just being managed for painkillers, they think it's something else, and yet they should be referred for further workup. The risk factors for breast cancer include heredity and family history, certain gene mutations, previous abnormal biopsy, chest wall radiation, high breast density, reproductive history, that is null parity, early menarche, and no breastfeeding history, hormonal replacement therapy, and generally a poor lifestyle of physical inactivity, tobacco and alcohol use, and even obesity. So the guideline for breast cancer screening, the age group 25 to 34, they should do a clinical breast exam every 3 years. And as you're all aware, this is something that does not require resources. So as a clinician, wherever you are as a nurse, this is something you can do for your patient without, much resources. Wherever you are, even from a level 1, from a dispensary, from a clinic, this is something that can be done. Mammogram is not recommended for this age. 35 to 39 years, clinical breast exam and ultrasound or mammogram is what is recommended, and that is every 1 to 3 years. 40 to 55 years, now this is where we need a clinical breast exam plus mammogram. Age 40 to 55, kindly ensure every year that they've gotten a mammogram. 56 to 74 years, they can get a mammogram and a clinical breast exam every 2 years. There's also a global initiative for cancer registry development. This is just useful. We need these registries for proper planning and for surveillance of the cancer. So the next initiative we have is for the children. We would like 60% survival rate for our children. The Western countries are reporting 80% survival for children with cancer, but in our setting, we are seeing 20 to 30% survival. So we are also implementing the global initiative on childhood cancer to get us to 60% survival. And some of the pillars of this childhood cancer survival, to increase the survival, include the first pillar is on centers of excellence. We'd like to have certain facilities that are centers of excellence in terms of childhood cancer treatment. We'd like a UHC, that is the Universal Health Package that can cater for these children from diagnosis all through treatment and rehabilitation. Then we need proper regimens that are suitable for our setting, and we need evaluation and monitoring with quality assurance. And these are the 6 common cancers that are covered under this. So we have the acute lymphoblastic leukemia, the Burkitt lymphoma, Hodgkin's, retinoblastoma, Wilms tumor, and low-grade glioma. Okay, so for this next session, I'll request my colleague to project. As we go to the policies. Dr. Masolo. As to the Kenyan policies. Okay, so the following are the previous slide, sorry. Yes, so in Kenya, these are the policy documents that are guiding our work in cancer control. Next, yes, that one. So we have the Kenya Cancer Policy 2019 to 2030. This is the overall policy document that just shows us where the country would like to go. Then we have the 2017 to 2022 Cancer Control Strategy. This one has now expired, and we have a new strategy document, 2023 to 2028. And as you can see on the screen, we have other documents on cancer specimen handling, breast cancer action plan. We have the cancer screening guidelines. We have the palliative care policy, the national cancer treatment protocols, and we even have a cancer communication strategy. And all these documents are available online. You can check the NCCP website. Next slide. So the cancer control strategy has a goal to reduce premature mortality from cancer in Kenya by 1/3 by the year 2028. And it has 5 pillars. The first one is on prevention and early detection. The second is on cancer imaging and pathology medicine. The next one is treatment, palliative care, and survivorship. And that is where we coordinate these activities. And the fourth one is on advocacy, partnerships, coordination, and financing. And the fifth one, which cuts across the other pillars, is on strategic information, registration, and research. So this is basically monitoring and evaluation. Next. So the first pillar on prevention and early detection has a goal to provide quality and equitable cancer prevention and early detection services. Next. And some of the objectives here is to reduce exposure to modifiable cancer risk factors such as smoking, alcohol, as well as the non-modifiable risk factors such as age, ethnicity, family history, and also to improve secondary prevention. And this is through screening programs. There's also an objective to strengthen early detection of childhood cancer. And there's one cancer that you can actually screen for, one childhood cancer that can be screened for. I don't know if we are all aware. Kindly, that's one question I would want your reactions on the chat. Which childhood cancer can we screen for? We only have one childhood cancer that we can screen for. So kindly put your responses on the chat box. Okay, next slide. So the second pillar is on cancer imaging, pathology, and laboratory medicine. This is actually the core. Before a diagnosis, you are not a cancer patient. So this is the true test that will actually give us a proper answer to whether you have cancer or not. Next. So the objectives are just to strengthen the diagnostic imaging, the pathology, as well as the human resources that are needed for cancer diagnosis. Next. On pillar 3, this is treatment, palliative care, and survivorship. So from this point now, we have a cancer patient. We need to initiate treatment. And the overarching goal here is to ensure timely initiation of comprehensive treatment, strengthening access to quality, sustainable care, and improving the quality of life for these cancer patients. Next. So the objectives include developing the necessary policies and to strengthen coordination between the relevant standards for provision of quality cancer management. Also to improve the availability and capacity of a skilled multidisciplinary team. In oncology, it's really, really crucial to have a skilled multidisciplinary team. This is not something that you do alone. You don't treat this patient alone. You need a multidisciplinary team. Also, we need to increase access to timely, comprehensive cancer care services. And this includes, more facilities, proper drugs that are needed, the proper HR and all that. Next. So pillar 4 is now on advocacy, partnerships, coordination, and financing. The overarching goal here is to forge and support effective advocacy and communication partnerships and mobilize resources for a robust cancer control response in Kenya. Next. Next. We can go to next. Yes, so the fifth pillar is on strategic information, registration, surveillance, and research. And the overarching goal is to implement a comprehensive and sustainable monitoring, evaluation, surveillance, research, and knowledge management. So basically, we need a research component because we need to know, are we doing the right thing? Are we getting the outcomes we'd like for our patients? So this is the pillar that actually tracks all this. Next. Let's skip to next. So there's this quote about at least 7 million lives could be saved over the next decade by identifying the most appropriate science for each country situation, by basing strong cancer responses on universal health coverage, and by mobilizing different stakeholders to work together. So this is a quote by Dr. Tedros, the Director General of WHO, on the importance of appropriate research for each country. Each country is different, and we need strong research for each country to just give us the proper responses. Okay, next. So, which are some of the recent advancements in cancer care in Kenya? Next. So, the Cancer Control Strategy 2017-2022 really highlighted the importance of us decentralizing cancer care across the country, so that it's not just one facility that is overwhelmed with this treatment. And as you can see on the left top side, we have the HPV vaccination that was started for girls aged 10 to 14, and this is ongoing even currently. You can get it at any of the public facilities. And the next picture on the right, that is the first radiotherapy facility outside Nairobi. This was in Mombasa at the first regional cancer center. It was being opened by the former president, and that was actually a big milestone. And on top of that, now we had other centers coming up in Nakuru and Garissa, where you're able to get radiotherapy services. So we also have the Integrated Molecular Imaging Center at KUTRH. That's also a big hospital that we're able to get even PET-CT that had not been available in our public facilities previously. And even now we have CyberKnife. So there's a lot of advancements that happened in that area. Next, please. So these are just the list of the regional cancer centers that our patients can get services. I've mentioned Nakuru, Garissa, and Mombasa. So in these three, you can get comprehensive cancer treatment, that is surgery, radiotherapy, and chemotherapy. And the other 8, you can get chemotherapy at any of these facilities. This really helps the patients not to travel for long distances to get basic chemotherapy that can really help their situation. Next, please. So in the year 2023, from the reports that we get every month, you can see these centers have really been busy. And the total new patients we recorded were 15,000, and the total follow-up patients are 92,000. So basically, these are the patients who would have been waiting, queuing at one facility and being given appointments for up to even a whole year before they can be seen, which was really contributing to poor outcomes. But currently, these patients are able to get very short wait times, and we are seeing very good survival rates. Next, please. So we are also supporting with oncology drugs. The ministry has been coordinating the supply of some essential oncology drugs. It's not all the drugs that we are able to provide as a ministry, but we are able to supply some of these drugs. And the drugs are supplied at the patients at no cost. They'll be catered for by the NHIF cover. And this includes morphine. Next, please. So in terms of partnerships and coordination, you remember our fourth pillar is on partnerships and coordination. We've been able to have a very good access programs that have really helped patients. An example is the Gleevec Access Program for CML patients. And this started at Nairobi Hospital over 20 years ago. And in 2021, it was decentralized to 4 public facilities: Nakuru, Kisumu, JTRH, Coast General, and MTRH. And we have over 2,000 patients in general who receive these drugs with no cost at all. They only pay for the lab works and some consultation fee, but the drugs they receive free of charge. And there's also a new breast cancer program by the same foundation that is going to start soon, that is really going to help breast cancer patients. We also have the Herceptin subcutaneous access program through Roche. And this was an MOU between the Ministry of Health, NHIF, and Roche that allows the patients to receive subsequent cycles of this drug with no out-of-pocket spending. Everything is catered for under the NHIF. We've also really benefited from capacity building, training programs for our healthcare workers through partnerships. Next. Also, we have the e-learning platforms that we've been using to sensitize our healthcare workers on the priority cancers. And this is just to increase your index of suspicion wherever you are. When this patient comes to you with persistent constipation and they're over 60 years, which kind of workup are you supposed to do? Do you keep giving them laxatives, or do you refer them to, for a diagnosis at a higher level facility? So these platforms are really useful. Next, please. Okay, so who is a cancer survivor? A cancer survivor is anyone living with a history of cancer from the moment of diagnosis through the remainder of life. So anyone who has received a diagnosis from that point, we call them a cancer survivor. We do not wait until you've finished treatment and you've been declared cancer-free, and now you're moving on with life. No, from even just that diagnosis, we know it's not an easy thing, and that's why we call them a cancer survivor. Next, please. So the essential components of survivorship. The first one, as I mentioned, a multidisciplinary team is very essential. We also need localized guidelines. We need community partnerships. These patients are not going to be living in silos. They need a community to surround them. The fourth one is longitudinal patient assessment, someone to track the patient during treatment, after treatment. And the fifth is the survivorship care plan. These patients, even if you finish treatment, you still need follow-up, 6 months, every year follow-up. And there's also the screening that you require even post-treatment, because you may get a recurrence of the cancer, you may get a new cancer coming up. So there's a survivorship care plan that is needed. Then you need education and empowerment. How do they stay cancer-free? How do they live a healthy lifestyle? How do they work with fellow survivors? How do they integrate back into the society? Then we also need sustainable resources and affordability. We need care coordination. There'll be many healthcare workers handling this patient. If the patient has gone back to Mashinani, maybe they were treated in Nairobi, are the lower level facilities able to understand that this is a patient post chemotherapy, and maybe the signs that they are showing is because of the reaction of chemotherapy? So we need that coordination between the healthcare workers team. Then we need information flow system and collaborative research. Next, please. So some of the challenges facing survivorship. The first is the health system challenges. I've mentioned the poor index of suspicion among health workers. And I believe if we really solve this, we will get a good number of our patients coming in at early stages, and they'll be able to respond better to treatment. Then there's lack of health education for patients. There's lack of adequate trained personnel. We've really seen the oncology personnel increasing in recent years, but we are still not at a good level. We still need more trained personnel. Then there's poor patient navigation. There's knowledge gaps in handling survivors. There's inadequate insurance cover. but we've been mobilizing that the new shift will actually cater to the fully to the oncology package. And I think that has actually been implemented. Some patient factors include low awareness levels, low acceptability of diagnosis and treatment. I'm sure you've probably seen this. Someone gets a diagnosis and they're not willing to start treatment for a variety of reasons, or they decide to go elsewhere, maybe to try other form of treatment, and most of the time they don't work, and then now they come back at a stage that is not really hopeful. So there's also that low acceptability, there's low insurance uptake, and we are hoping now people will take up the new shift that will really help them to just get protection against the catastrophic health expenditures associated especially with the oncology diagnosis and treatment. Then some societal factors, there's a lot of myths and misconceptions. There's low awareness levels. People think, you are bewitched, that's why you have cancer, or your family is bewitched, or I don't know, you did something wrong, you know. So there's a lot of misconceptions in the society. And for this, we need proper public education. Next, please. So there's a study that was conducted at the Moi Teaching and Referral Hospital on factors influencing the time to diagnosis and treatment among the pediatric oncology patients in Kenya. And it was noted that there was a health system delay of up to 87 days before a patient got a diagnosis. Yeah, these patients would come within maybe 4 days of onset of symptom, but by the time they actually get a full diagnosis and they're started on treatment, it will take almost a whole 3 months. So we also need to check our health systems and how we can make this better. Next, please. So some of the ongoing work around survivorship includes the expansion of diagnostic and treatment infrastructure. So this is just more centers, more facilities that are able to offer diagnosis and treatment, because as we've said, when this patient gets a diagnosis, they need to start comprehensive treatment immediately. This really improves their chances of beating the cancer. Also, we are expanding the oncology package, benefit package in SHIF, and this will cover screening, diagnosis, as well as treatment. There's also capacity building for the primary health workforce, as well as the specialized workforce. Then we're also addressing the commodities and supplies challenges for cancer treatment and rehabilitation. We know there's been some challenges in terms of cancer medicines, so we're also addressing that, as well as the rehabilitation items. Also, we are strengthening research and training in this field because we've been seeing a lot of cancer cases recently. We are trying to figure out what could be the cause of this, how are patients responding to the treatment, and so forth. Next, please. So in summary, early detection really saves lives. That's why we are seeing better survival rates in the West, because they do frequent health checkups, and this really helps the outcomes. So it's important for us to really preach this gospel that early detection saves lives to all our patients. Whenever you find your patient has come, even for family planning, kindly just start the conversation of screening, and you screen the whole woman. If it's cervical cancer screening you're doing, also carry out the clinical breast exam. This really helps us to cover the patient fully. Cancer survivorship work begins from diagnosis. As we've said, a cancer survivor is someone who has gotten a cancer diagnosis. Then the clinical team must work together with other health professionals. So we've said it's a multidisciplinary team. Psychological support is vital in the whole process, and this is both for the patient, their families, even the health workforce. We know it's not easy to handle these patients, and some get poor outcomes. So even the health workforce, you also need to find a way to get psychological support. Then there's proper need for patient education and navigation. Also, sensitization on treatment adherence. This has been a major challenge. Patients start treatment and they abandon. It's something that we really need to encourage them to keep up. Also, we need to really leverage on survivorship champions. And we're going to hear from one of our survivors today. And such survivors are really, really useful. They help to speak to other patients and other survivors, and they encourage each other to keep on accessing treatment, to keep on living a healthy lifestyle, and they even educate the general public on the need of coming out to get screened frequently, because there are testimony that we got screened, we got treated, and we are still here. So it's not all gloom. There is life beyond a cancer diagnosis. So also there's need for collaboration across health agencies and non-health agencies. We need development partners to keep supporting us to achieve all these policies that we've laid out, because it's really necessary for us to partner together. Next, please. So cancer survivorship isn't about just being alive after cancer. It's about living life as fully as possible. So we would really want to support our cancer patients. And it's not just about the policies that the ministry is also putting. Even out there as a society, how can we support these patients? The stigma that some of them face, why are we subjecting them to stigma? This is someone who has already gone through a very hard experience. How can we support them? How can we reintegrate them into the society? How can we just offer a shoulder even as they're going through treatment? It's very important. Next, please. So this year we were able to have a Cancer Survivors Festival. Every year we try to just do something to bring the survivors together, to hear what they have to say in terms of the challenges they are facing, and to generally celebrate life. It's important. Every minute they're here with us, we are celebrating them. We are proud of them for their resilience through the treatment, through the whole process, and even as they integrate back into the society, we are still supporting them and holding their hands. Next, please. So I'll conclude with this. This was supposed to be part of our poll questions, that we just need to know the key signs and symptoms for each of these cancers. It is very useful. You're going to see some of these patients coming to you. And if you know some of these things that could be a warning sign or an early sign and symptom for cancer, it would be really useful for you to refer them to a proper oncologist. So for cancer of the cervix, there'll be postcoital bleeding, excessive vaginal discharge. For breast, there'll be a lump in the breast. And this is why even self-breast exam is really important. Can we encourage our patients to do the monthly self-breast exam? Then there'll be maybe change in bowel habits in terms of colorectal cancer, unexplained weight loss, blood in the stool. So we need to also empower our patients to keep checking their bowels. How are their stool looking? If you find someone with unexplained weight loss, could you do some further workup on this? Cancer of the stomach, you can have upper abdominal pain, recent onset of indigestion and weight loss. And this is where you find many people are saying, oh, I have ulcers. I've been told I have ulcers, H. pylori. We need to do further workup for our patients. Urinary bladder, you can find there's pain and frequent and uneasy urination. There's blood in urine. Some of these things, we keep seeing them and they're really useful. As a sign that there could be something wrong. Prostate cancer, this is something very common. You've seen it's among the top 5. You find these men have difficulty in urination. There's frequent nocturnal urination. So are we speaking to our fathers, our grandfathers, this older generation of men? When I know men don't also like discussing their issues. So you'll find maybe they just keep quiet. But when you find these patients, kindly just interrogate them further if they have any of these issues, and you encourage them to get further workup. And the last one I'll speak on is on retinoblastoma. this is you can find a white spot in the pupil in a child, and this can be picked even before the child is 1 year. This is something that can be seen clearly. So this is actually the one type of cancer that can be screened in children. So we, as healthcare workers, we really need to do this. We need to check out our patients when they have this and refer them to the higher levels. So I'll end my presentation there. So there's a lot that has been done in this space, and there is hope. And that's what we want to tell our patients. It's not all gloom. There is hope. You can survive. There's a lot of infrastructure that the ministry is putting in place. There's a lot of support in terms of drugs, in terms of the oncology workforce, and it's all going to be fine. So thank you very much. Solomon, I'm done. Thank you. Dr. Susan, you can go up next.
Okay. Thank you so much, Dr. Jeffrita. Let me start this. I hope all of you can now see my screen. Okay. So I'm going to speak on survivorship, and of course with a bias towards pediatric oncology, because that is what I am currently studying. So I'll start off with a quote. So everyone who is born holds a dual citizenship in the kingdom of the well and in the kingdom of the sick. Although we prefer to use the good passports, sooner or later, each of us is obliged to identify ourselves as citizens of that other place. And this quote, I picked it from one of the papers that I read as I've been doing my studies in pediatric oncology survivorship. And we realized that for most of these survivors, this is something they always have to think about. Which passport do they need to hold? Are they well? Are they not well? So, who is a cancer survivor? I know Dr. Joyfrida has mentioned who a cancer survivor is, but the question, as from that quote, and for most survivors, is, am I?
Sorry,
Yes.
Dr. Susan. Please go to a slideshow.
I'm on slideshow. There.
No. Slideshow. Just go to there.
Here.
Yeah.
Are you now able to see my current slide? Okay. Are you able to?
Not yet. I don't know if I'm the only one.
Dr. Joyfrida had already given us a definition of survivorship, but we realized that there are varied definitions. And when you talk about a survivor, the survivors themselves will ask you, am I a patient anymore? Or is the cancer patient a survivor? Because when you look at the definition that we have been given, is that an individual is considered a cancer survivor from the time of diagnosis throughout the balance of life. Okay, and then other literature, including the Kenya Ministry of Health, Kenya Palliative Care Policy 2021 to 2030, will tell us that survivorship focuses on the health and life of a person from post-treatment until the end of life. So we have varied definitions, and these varied definitions create some a form of confusion to our patients and our survivors, because you'll have survivors asking themselves, and even doctors and the caregivers asking, is a survivor no longer a patient? We need to take them back for screening. We need to take them, they need to be checked for late effects. Are they still patients, or are they now off the hook? Okay, so, and is a cancer patient a survivor? And we did, when you look at literature, and you find that there's some studies that show that some survivors feel like they're imposters when they say, I am a survivor, but I still have these certain needs. And then you have patients who feel like, I cannot say I am a survivor. I am still under treatment. I don't know what my fate is, etc. And so we have varied definitions, and this is a global discourse, and probably we will get a better definition once people do a lot more research on these people, once people start including survivors in their definitions. And for purposes of this presentation, I'd want us to focus on survivorship that focuses on the health and life of a person from post-treatment until the end of life. So what do we know about survivors in Kenya? So when you look at pediatric oncology survivors, we have a low number of survivors when you compare ourselves to high-income countries. We have less than 30% survivorship, while in high-income countries, we have 80 to 90% survivorship for certain cancers. So numbers are gradually increasing, and this is due to advancements in treatment modalities and cancer awareness, even globally, but even as you've seen from the previous presentation, that our country is really, our government is really putting in a lot of work to make sure that there's awareness, there's treatment that is being offered. And survivors will experience late effects. They will experience late effects of cancer treatment. They will experience late effects of their own experience during treatment. And these late effects will include physical late effects, emotional late effects, psychological late effects, and even financial late effects. So when we look at physical late effects, for instance, in children, some drugs will cause problems with growth hormones, and will have our children not growing up in stature as they're supposed to grow. We'll have cancer treatment that may cause hearing loss. Some chemotherapy, some radiation to the head might cause hearing loss. Heart damage, some of the drugs that we use might actually cause heart damage. And this include, we can also have certain agents, certain treatments that will also cause secondary cancers. So radiation, certain drugs have been shown to cause secondary cancers in our survivors. Then abnormal bone growth or muscle growth, okay, which can be caused by also chemotherapy, radiation, or surgery that we give these patients when we try to treat them. Cognitive defects, okay, especially for brain cancer patients, okay. Low thyroid hormone, which can be caused by radiation to the neck. Reduced lung function, treatment-related obesity and metabolic syndromes, and infertility, which we will see in a lot of adult pediatric oncology survivors will express this concern that they're scared after this treatment. What happens? I might have issues with infertility. So these are some of the physical late effects that some of our survivors will experience. We also have psychosocial issues in our survivors. Some of them are spiritual. You find that they will start having certain uncertainties. They will lose hope. They will lose a sense of spirituality. So you'll find patients who previously believed in God, they do not believe in God anymore, for instance, and loss of a purpose and mission in life. Okay. Then we have social issues, whereby you'll have patients expressing fear. They will lose work. Some of them lose work because of their cancer diagnosis. family distress, and you see this a lot in parents. Okay, so parents, for instance, if a child gets diagnosed with cancer, parents will come to the hospital and they will stay with that child for months, with that child without going back home. So that means they won't go to work. And you know the kind of patients that we have in our setup, the kind of families that we have in our setup, that they come from very low backgrounds, and therefore they need to be working. And if the work is usually daily, what we call juakali, then what happens is that they end up losing their jobs. Family distress, children, the siblings to these survivors or to these patients are in distress. They miss their brother, they miss their sister, they don't know what's happening to their sister. The whole family, the parent is worried about the child, is also worried about the children at home, they're worried about finances. So there's a lot of family distress, economic hardships, especially when it comes to the fact that maybe some of them cannot even afford paying for NHIF and have to pay out of pocket for some of the treatments. Okay, changed relationships. We've had cases where parents come to the hospital, and once a cancer diagnosis is made, one, they start blaming each other. A parent leaves another. So a father abandons the family, a mother abandons the family. We've seen such things. We've also seen that there's an impact on sexuality and fertility, and this is, as I've said, very common among the adult pediatric oncology survivors. They're scared. Who's going to love me now? I might not get any children. They're scared of even being able to, what we call, tune a girl or a boy, because they feel like if they know about my cancer diagnosis, then they might not want me anymore. So such things. There's also psychological impact of what we call pediatric oncology treatments. This is the anxiety that comes with the cancer diagnosis. Okay, the anxiety about school when these children are in the hospital. Are they going? They're missing out on school. They're missing out on playing with their friends. They're missing a lot of things. The parents are also missing a lot. Okay, so the anxiety of whether their child is going to get better, of whether their child will live and be an adult one day. The challenges or the worries that will this child ever get children, etc. There's also a sense of loss of control from both the survivors and the parents to these survivors. They feel like they've lost control about what is happening in their lives of their children. And there's a change in appearance. A child walked in, they were well, they were walking, they were running, they were diagnosed with cancer. One of their legs had to go, and I had to go. Something had to be done and they had to get an amputation of their hand, etc. And these changes in appearance have an effect on their whole well-being in terms of whether they feel accepted by society. How do people look at them? Are they now able to do what they used to do before? So there's a general disruption, and because of these changes in appearance, there's also this feeling of being a bit useless. And so when we do our studies, especially when we do our studies looking at stigma in survivorship, you find that some of them feel like they are no longer useful in society. Because of their diagnosis, they feel like they're a bit useless. Physical, sometimes we have some psychosocial issues that are physical, whereby patients will report pain, they report being fatigued, they report even not eating sometimes because of the stresses that are availed to them. So these are some of the psychosocial issues that pediatric oncology survivors and even adult survivors would experience. So at MTRH, we did a study in MTRH, and we focused on asking the parents to these pediatric oncology survivors about certain late effects that they might experience. And 72% experienced late effects. And you can see the list of late effects that are on that slide. The 72% of our survivors had experienced late effects, with pain being one of the major ones, and fatigue by eye problems. They were having gastroenterology problems, shortness in length, which we've talked about, ENT issues, orthopedic problems, okay? cognitive problems, heart problems, teeth problems, hearing loss, psychological problems. So these parents were able to report some of these things in their children. They will say that my child sometimes just sits and stares in space. Okay, my child who used to be very vibrant is nowadays very quiet. Such things. So it shows that there's something that is going on in their mind because of their cancer diagnosis that they did get. And you can see that most of the late effects were mild, at least 47%, but quite a number were also moderate and severe. So we are having a group of survivors in this country who are experiencing a lot of late effects, and they're also severe and moderate. Okay, and so this is something that we need to sit down as a country and actually look at in terms of how do we cater for the needs of this current group. 11% of survivors in this study were limited in their daily activities. We are talking about a survivor who in the previous 30 days before the study wasn't able to go and run around with other children, wasn't able to focus and do their homework, wasn't because of their cancer diagnosis or because of something that happened during their cancer diagnosis, in terms of maybe they had their right hand being amputated and they cannot be able to write using it. They're learning to write it using the left. One who used to walk very well, the leg was amputated, and therefore they can't go out and play with the other kids as per usual as they used to do it. And so this becomes their new norm, and 11% of our study population were limited in their daily activities. Then greater than 70% of these patients had more than one late effect. So meaning you can say that only one patient experienced pain, another patient experienced tiredness or fatigue or eye problems. No, a majority of them had 2, 3, 4. There were others who even up to 7, 8 late effects per one survivor. And so this tells us that we have survivors, yes, but we also have issues that we need to start addressing. So when we looked at these were so the previous results were from parents of pediatric oncology survivors. Then we looked at adult survivors. These are adults who had childhood cancer before and had now survived into adulthood. And when we looked at them in terms of stigma and what they might have experienced, is that 50% reported negative feelings. They reported that they were worried, scared, lonely, sad, hopeless, depressed. They had trouble sleeping. Some of them were angry and ashamed. And this was usually at the situation at school. So they had these negative feelings that they were harboring. Okay, and then survivors were excluded from school activities. At least 23% of these adult survivors remembered that they were excluded from school activities, and 15% of them were bullied in school. So they had children bullying them in school, and we had cases of even teachers bullying them. Then 96% could not openly speak about cancer to all community members. So for all the community members that we chose to include in the study, and we asked them, have you told this one about your cancer diagnosis? Have you told this one about your cancer diagnosis? At least 96% could not. They felt like they could not be able to tell certain people about their cancer diagnosis. And this is because they know that people think that cancer is a curse, it's contagious, it's inheritable, and they didn't want that stigma on themselves. And 35% of these adult survivors felt that their marital prospects were negatively affected by their cancer history. So you can imagine they are very scared of reaching out, trying to get spouse. They're also scared because they feel like people think that they will get children who have pediatric oncology cancers, and therefore they felt that it will negatively impact their marital prospects. So that's just a sneak peek of what we've done in terms of survivorship research. So when you look at this process, on the blue, when you look at the blue line, I want you to do something. I want you to raise a finger if you have or you do this at your facility. So cancer survivors in your facility are assessed for emotional and psychological effects of cancer and its treatment. Okay, so you hold up your finger, you just raise a finger if you think that is correct in your setup. Also, number 2, cancer survivors are assessed for physical effects following primary treatment. So do you assess them for pain, fatigue, weight loss, or gain? Do you do this? These are after treatment. Another thing is, have you stratified them to appropriate models of care based on factors such as current needs and predicted risks? Have you? Because we know that different cancers have different risks. Okay, we know that even in survivors, we know that if this patient had a certain cancer, they are likely to have certain risks, and because this is because of the treatment that they receive, and even sometimes inherently the type of cancer that they had. So are you able to stratify your patients and give them care according to their risks as survivors? Then, are you able to provide treatment or referrals to manage physical effects of cancer and its treatment? Are you able to provide treatment or referrals to manage physical effects of cancer and its treatment? Are we the ones who finish treating our patients and tell them, now you're well, you finished your course of cancer, we've checked, you're good to go, please go home, okay, don't come back, okay? Are you able to assess for practical and social effects of cancer and its treatment, such as relationship difficulties, financial challenges, education, employment, and return to work? I can see from the Q&A, I've seen survivors asking about them going back to work. Okay, we usually are very focused on certain things, late effects. We know that this patient might get a heart failure because of doxorubicin. So let's do something about that. Okay, let's keep checking. But have you asked this patient what is their issue, what they feel is their current need at this point? Okay, so have you assessed for practical and social effects of cancer and its treatment? Have you provided access to a survivorship program which addresses the needs of cancer survivors either on site or by referral? And I am just asking, do you have a cancer survivorship program in your hospital? Okay. Are you able to assess your cancer survivors for their risk of recurrent or new cancers, including family history as necessary? Are you able to do that? We've just mentioned about retinoblastoma from the previous slide. Are you doing these things proactively, assessing for the risk of recurrence of a new cancer, including family history? Okay. Do you provide your patients with a survivorship care plan? Do you, after they finish their treatment, do you provide them with a survivorship care plan? And do you give them recommendations regarding surveillance for recurrent or new cancers? Are you able to provide them with treatment or referrals to manage psychosocial effects, such as psychological services? We've been talking about multidisciplinary team. Are you able to note that your patient is having some anxiety problems, is having some depressive thoughts, and you need to be able to refer them? Are you able to do these things? So if you raised all your fingers, you should have all your 10 fingers up. But I think I know what your score was. And I'm sure most of you didn't score more than 4. Okay, so most of you didn't get more than half, and probably you got a fail. And so what does this tell us in this setup? What does this tell us in our current setup in Kenya is that we need survivorship care. There is a need for survivorship care. Our government is doing a lot in terms of making sure that we are having treatment. We are treating a lot of patients. We are making sure that there's awareness. There are a lot of things that are being done to make sure that this patient comes and gets treated and survives the cancer. But what happens after they survive the cancer is what now we want to look at. Because if we are going to have an increase in the number of survivors, then we need survivorship care. So what are the 4 components of survivorship care that we need to focus on? So the first one is prevention of recurrent and new cancers, okay? And then number 2, surveillance for recurrent or secondary cancers based on their risks. We know that certain patients will have a risk for certain cancers and certain and a recurrence, and therefore we need to be able to surveil to be able to have surveillance measures for that. Then intervention for consequences of cancers and its treatment. What are we doing? We know that for instance, in our study, we know that most of our patients are experiencing pain. What are people doing out there to manage their pain? Are they taking Panadol every day? Is that sustainable? Do we need to do something else for these patients in terms of making sure that they are able to handle whatever they are going through? Is it if it's cancer related pain, if it's psychological pain, are they able to be treated? Then coordinated care between healthcare providers, which is very important because as we've mentioned, some of us, our children will get treated at MTRH and they live in Turkana. And so you need to be able to communicate, you need to be able to coordinate and say, we've treated this patient and we are releasing this patient back to you in Turkana. And this is what we would recommend that you do with this patient. This is what we want this patient to continue being done for. So coordinated care between health providers and hospitals is very important. So we all start from somewhere, and we see that there are things that can be done to make sure that the lives of our survivors are not only quality, but they are also very well thought out. So we need to do some things. We need to start on education on survivorship. If I was to carry out a poll here and ask all the healthcare providers who are in this webinar to raise up their hand and mention if they have received any form of survivorship education during their education years, that is undergraduate or even their masters. I kid you not, I know from what we've been looking in our various curriculums, there is no education on survivorship care for our healthcare workers. And so that is something that we need to start making sure that it is being taught. People understand that survivors, you will treat cancer, but they will have some needs, and we will need to keep following them up for the rest of their lives. And so we need to be able to plan for them. We need to be able to treat them. Educate your survivors, your patients, your parents, your caregivers. They need to be able to be educated about survivorship. They need to be told that yes, your patient or your child or your relative came, we treated them because of this cancer, and we've finished treating them. We can see that they do not have any cancer as of now, but they have certain risks, and we will want to see them through these various intervals for the following years. We want to see them every now and then. Then we need to have interventions, something such as a survivorship care plan, okay, that just states that this patient had this cancer, received this treatment, and because of that, these are their risks, okay? And if these are their risks, if they experience certain things, they need to be able to come for certain appointments, okay? Scheduled or unscheduled, they need to come for some of these appointments, and also advice on how they're supposed to live their psychosocial lives. How are they supposed to move into the world? How are they supposed to, for instance, children, how are they supposed to go back to school? Like, talk to them, tell them, have them being talked to about some of the things that they might encounter once they become cancer survivors. So advice on how they will, what they will have, what they need to stop alcohol or smoking, etc. So some of these things, advice. Then let's do research on survivorship. Let's do research on survivorship. Let's make sure that there's data from our country on survivorship. We don't have enough data from various centers, treatment centers in our country on on survivorship. How many patients are we seeing? How many are surviving? What are their challenges? What is this center doing better than the other in terms of survivorship? Then we need to be able to have support groups and survivorship associations for our survivors. Let's try and do something in that. In that end, I can see that there was, for instance, a survivorship festival. Let it be something that is more frequent. Let these people feel like they belong, where they can be able to air their challenges, where they can be able to say, I'm facing this challenge as a cancer survivor, and what does the government need to be able to do to help me? And I want to stop there by concluding with what we are doing at MTRH. Currently, we are doing survivorship intervention study that has several arms. One of them is educating our survivors, our parents of the survivors, and also educating the healthcare workers. Another thing that we've been able to come up with is follow-up forms to ensure that our healthcare workers are able to pick out late effects from our survivors as they come for these encounters. They're able to pick out if these patients are experiencing late effects and be able to refer them appropriately. Thank you.
Thank you. Thank you so much, Dr. Susan, for giving us an elaborate presentation on the survivorship care plans and the key areas that we need to address, especially when we are dealing with our patients. So thank you also, Dr. Joyfrida, for talking to us about the policy perspectives as pertaining to cancer treatment, cancer management, and cancer treatment at large. At this moment, I'm also joined by one of the panelists who is a cancer survivor, and I want to bring her in to talk to us briefly about her experience. So, Madam Eva Alela, if you can hear me, kindly unmute and perhaps say a word of good afternoon to the members as we start this session. Eve, can you hear me?
Yes, I can hear you. Can you hear me?
Yes, I can hear you. Good afternoon.
Good afternoon.
Karibu sana to this panel. Please talk to us about your experience. How did you know that something was wrong with you? Walk with us how you went to seek for help.
Okay. So I wasn't really keen on my regular checks. I would, do the self-examination just maybe when I came across, a write-up somewhere, or in October when everyone was talking about breast cancer. So one morning when I was taking a bath, I felt a lump above my right breast, and it felt quite big. And I was wondering, I've not felt this thing. Even yesterday, I didn't feel it. Last week, I didn't feel it. Where has it come from? So I was concerned because it was big. And I went to be checked. I first met a breast surgeon, and she took a family history. And that already was a red flag because I have a strong family history of breast cancer. My paternal grandmother passed on from breast cancer in the 1940s. After that, in 2005, I lost a first cousin from my paternal side to breast cancer. And then about a year later, my uncle, paternal, was diagnosed with breast cancer. So with that, in as much as my doctor told me, 8 out of 10 lumps are nothing, but she told me I have a high risk. So, that prompted quick intervention. So I went through the tests. I had a mammogram, I had an ultrasound, I had an MRI. Then eventually when they confirmed that the lump was indeed suspicious, I had a biopsy, which confirmed that I had breast cancer. Relatively early stage, it was stage 2A, so it had not spread beyond the breast tissue. So I was put on a treatment plan. I first had, it was also confirmed that I had triple negative breast cancer, which was expected because of the family history. I think it has a higher genetic predisposition compared to other forms of breast cancer. So I had surgery, the lump was removed, some lymph nodes were checked.
Before you go to treatment,
yes,
your doctor is seated there. You are getting these test results, and
yes,
the doctor is telling you that it has been confirmed that it's a case for breast cancer.
yes.
How did you take it? Share with us the experience on that moment you are receiving the test results.
Okay, so I was fortunate to have a very pleasant doctor, and she was also very, very generous with information. So every time she was explaining every test she was sending me, she would really be open and even draw pictures, to explain to me what is going on. So on that particular day, when I went to receive the biopsy results, I'd previously been going by myself. So that day I was accompanied by my spouse. So I asked her if I can come in with him, and she said, of course, just come in with him. So we sat, and then she sat at her computer. And then she also had this habit of asking me to sit next to her. Then she would open the computer and explain to me, what is going on. So in the usual style, she asked me to sit next to her. And then, so she opened the results, and then she told me, so the biopsy results are back, and it is confirmed that indeed you have breast cancer. And I said, okay. Then she asked me if I have any questions. I told her not at the moment. Of course, this was shocking. In as much as you always hope that one day I'll be told, oh, the scan was wrong, you're okay. The MRI was wrong, you're okay. So now this was the final nail to the coffin when the biopsy results came. And so she started telling me about, she told me, I understand this is hard news for you to take in right now, but you can go, home and absorb the news and think about it. You can always text me or call me if any questions come to mind. I don't expect you to even have anything to tell me right now. And I know it's hard. You may also, want to cry and feel heartbroken and stuff. So when she told me that, I broke down, and she held my hand, and my spouse also came and held my hand. So they just gave me a moment. I cried, and I know once I finished and I composed myself, now we continued now to talk about the next steps, which was now additional tests that she was going to do to check if the cancer now was, beyond the breast and the lymph nodes. So I was sent for CT scan of the chest, abdominal ultrasound, and the likes. So yeah, that was how she broke the news to me.
Oh, that was interesting. She walked, or he walked with you perfectly throughout that journey. Maybe how long did you take to get that cancer diagnosis from the time the biopsy is taken to the time you get the results? And how will you rate it? Did they delay it, or it was quite fast? Go on.
Yes. So the results were ready within a week, but my doctor fell sick, and I wasn't able to go back. At some point, after about 2 weeks, when I called, the hospital asked me if I want to see another doctor because they're not sure when my doctor would return. I chose to wait, and I think the reason why I chose to wait was to postpone the inevitable, because I didn't want to receive this news. But I would say if my doctor didn't fall ill, it would have been 1 week between biopsy and between getting the results.
Oh, thank you. That was fast enough. Now you've been told that you have a cancer
Yes.
diagnosis. you're ready to start treatment.
Yes.
Probably as we go through treatment process and treatment planning, I also want to know how long it took you between the time you're given a cancer diagnosis, the time you start treatment, and you also talk to us about how the treatment process was.
Okay. So these are dates that we never forget. So I got the biopsy results came on May 13th. That was in 2020. So I'm 4 years out now. And so the following weeks was spent between having the chest CT, abdominal CT, and getting theater ready. So I got the surgery on June 1st. That is about a little over 2 weeks after the confirmation of the breast cancer. So after that, I was given 6 weeks to recover from the surgery. It was quite uneventful. So after I stayed in hospital for about 3 days, went back home, went for review. After 1 week, the drain was removed. Then I went for another 1 week just to check how the wound was healing. Then after 2 weeks, then when I was cleared, I think about 3 weeks to a month after the surgery, I was cleared now and discharged to the medical oncologist, who I went to see, and so I began chemo 6 weeks after the surgery. So that was July 15th. That is when I began chemo. So I had my sessions every 3 weeks, and I don't remember. I didn't miss any session. I think I was able to get every time I went, I would get it. Apart from I think during must have been the 3rd or the 4th chemo. When I went to see the doctor, I complained about excessive fatigue and breathlessness on even the smallest of activities. And she told me she's suspecting I may have a blood clot. She sent me for a chest CT, which indeed confirmed that I had 3 blood clots in my lungs, which she said number 1 could be because of the surgery, number 2 could be chemo, number 3 the cancer, because anything could have caused it. So I was immediately put on blood thinners. So that is the only time my chemo was delayed, because I couldn't have it that day. So I think so I continued with the blood thinners for 6 months. Yeah, then I had my chemo going on for, I had 8 cycles, which I finished in December. So after I finished chemo, so during chemo, it was terrible. I think chemo is one of the worst things anybody can go through. I think what we see, we just see hair loss, we see maybe weight loss in some people, but there is so much that goes on within the patient's body, like excessive. I used to be so tired, and sometimes I would be very, very moody, and I would have unexplained pains in my body. Sometimes my bones would ache, sometimes my neck pain, sometimes I feel like my jaw is frozen. I have funny headache at the back of my head. And this I would always communicate with the doctors, and every time I'd be given something to help with that relief. And some of these symptoms I had been told prior, so I expected them. I think the one thing that I expected, which I didn't get, was nausea and vomiting. So I did not have nausea or vomit even once throughout chemo. So I'm grateful that I missed that side effect, which I know I've had instances of vomiting before. And on top of the exhaustion that comes with the cancer and the chemo, I wouldn't imagine what a patient goes through when they have the additional pain and stress that comes when they vomit. So yeah, when I finished chemo, so my physician was now discharging me to radio, and it was I think it was December around 10th thereabout. So I told her I need leave from treatment, and I told her, can I rest? Yes.
December of the same year? That is
Yes, December of
2020.
the same year. It was still 2020. So yeah, so I went through treatment during the COVID year. I think just to comment, I don't know whether it was a blessing or a curse, because one, we know that chemo comes with immunosuppression. So everybody was wearing a mask and cleaning up their hands. So in some way, I was protected. On the flip side, I know there are so many people who would have wanted to visit and support me, who could not come, of course, because one, to protect me, and we were all keeping to ourselves during COVID. So the doctor gave me a break, and and she told me, please make sure you go to radiology the first week of January so you can rest. I just told her I need to recover from this past 6 months. So come January, I reported to the radio clinic. So I saw the radiotherapist before. Then he told me what to expect. I might have burns on my skin, and what I may do. You may need to apply some creams, which he gave me a few. He mentioned a few that I can use. So I began. Oh, I didn't mention. I think I saw somebody talking about work at some point in the questions. So I resumed work. We were working from home. I think that's another blessing that came. So I continued working from home until September, when now I had to go back to the office. Yeah, but I would take off days for chemo. Then, so in January, when I was going for radio, I was already fully back to work. So I'd go for radio in the morning and then go to work for the 20 sessions that I had. And then I completed my radio with not much incidences. Yeah, so I marked now, I celebrated the end of my treatment. So basically that was how my treatment went.
Oh, thank you so much. But something that has caught me here, you still going on treatment at the same time working. How did you balance the two? And probably if there will be policymakers here, will you suggest that it's possible for people to continue getting treatment and going to work?
It was difficult.
From your experience?
Yeah, it was difficult, but you see, sometimes in my mind, I'm thinking this is the employer who is paying for my medical. So I need to continue working because I need this medical cover. It was difficult sometimes because I would really be exhausted. But it would have been my wish to actually stay at home or work from home. But circumstances just forced me to go back to work. So I would only take off days during the chemo days.
Oh, that was quite an experience, actually an event. I want to ask a general question. Probably throughout your treatment process, and did you feel that you were supported by your healthcare workers throughout the treatment process?
Yes, I think for me, yes. I think for me, from the first doctor that I encountered, she was very supportive and very free with information. And I think that went on to the medical oncologist and radio. I wouldn't say there was really much there, but every time I would go, they would talk to me, check how I am, ask me if there's any complaint or any concern that I have. And I think even during chemo, the nurses who were attending to me and administering the drugs, they would always spend a few minutes having a conversation and just asking me generally how I feel and if I need anything, and if there's anything I would like to share with them. So I felt relevantly supported.
Thank you so much. That's a nice experience. You felt so much supported. But then again, if here you are, you've completed your treatment, a survivor, as per what we've just learned today.
Yes.
Transiting to that survivorship phase, probably did the healthcare professionals take time to share with you about the survivorship plan, about the follow-up care? Talk to us about it.
So once I finished treatment, I think all I was told was I will need to be going for review every 3 months. And I was told, you know, if you feel anything in between, before the 3 months, you can always come in and be seen. So the reviews were basically to check how I'm doing, to ask if there's you know, anything going on, any concern that I need to, that I would want to share. I think so. Basically, it was more me telling, and the doctor was more into checking how I'm doing generally. So you know, it was general. I wouldn't say there was anything specific towards how to survive, unless maybe I asked a question to that effect.
Oh, thank you so much for sharing to us that experience. Maybe the last question you shared to us has been the experience like post-treatment, life post-treatment.
So I must say that during treatment, I had a lot of support from everybody around me. And the moment treatment ends, I think everybody assumes that your journey with cancer is over. So, and now I'm on my own, unless maybe I shout out about it. So yeah, so I guess that I've had to navigate on my own, you know, look for resources where I can get support. So in terms of even the support groups that I'm in, those are, you know, I just happened to find them because I was looking. Yeah, so it's like I'm just generally navigating life, especially outside the cancer, on my own. So the things like, what do I need to do physically, taking care of my mental health, looking at the lifestyle changes that I need to make. Just it's a journey that I am doing by myself. And now with the support groups or the organizations that I am part of, this is where now we are having these conversations on survivorship.
Oh, thank you so much. Maybe now the last of the last. There are
Yes.
patients here who are listening to us. There are survivors here who are listening to us. What will be your parting shot to them?
I think my parting shot would be know yourself and know really what cancer you had, and understand what life is after that cancer, and be very open with your doctor, because you see, they can only answer the questions that we ask. We cannot just go and assume that they're going to feed us all the information that we need if we don't ask them questions. So we really must ask the questions so that they're able to answer us and guide us. And another thing is, don't suffer alone. I think there are very many people out there who would want to work with you, friends, relatives, and support groups that are able to support you depending on the type of cancer that you have. And I think there are many things we struggle with that we only feel comfortable talking to maybe somebody who has gone through the same, and that would be the benefit of being in a support group. And I think sometimes, like for me, I get satisfaction in being there for other people. So I've involved myself in some advocacy work. I have worked with some patients who've been diagnosed after me. I've taken it upon myself to be a social media noisemaker every month, where I encourage and remind women to do their monthly self-breast examinations and consult a medic if they find anything abnormal. And I would encourage the patients to be active, you know, get involved with a hobby or something that that you like doing. And yeah, just try and plan around your life. I know we always live with this constant fear of recurrence. I think I've had 2 scares, but fortunately, it was nothing. So we just take it one day at a time. Live your best life, enjoy the things you like doing. And the last one is there's a lot of myths and misinformation going around relating to cancer. There are people who are ready to make money out of our desperation because they know we are desperate to fight this cancer. We are desperate to prevent any recurrence, and they will come and sell you all sorts of things that they promise you is going to kill cancer cells. It's going to do this, it's going to do that. I would really encourage us to read widely, consult your doctors, consult the specialists before you take any interventions that are offered by someone who is more interested in fattening their pocket rather than what is beneficial to your life. So yeah, and with that, I would like to thank you for the opportunity. And I hope I've been helpful. I will type my social media handle. So once in a while, I post some tips, especially on breast cancer. Thank you.
Thank you so much, Eve, for being available for us. Thank you for the encouragement. Thank you even for the advocacy issues and the advocacy work that you're carrying on. And thank you for joining our platform. At this time, the moment, I want us to move to the question and answer session and probably look at what has been asked on that section. And I'll be throwing it to our panelists to try and answer us. One of our panelists wants to know if there are any tests that they are supposed to be doing post-treatment. It's a case of lymphoma. So I want to ask Dr. Susan, probably this is a patient who's done with treatment. Are there specific tests or what is the care plan like? Please share with us, Dr. Susan.
So when it comes to specific tests, hello?
Yes, go on.
Yes. So yes. So when you have a survivor who has certain, it depends with the cancer, number one. So there are certain cancers that we know that we need to keep periodically to do certain tests, okay? But also, what we know is that the guidelines that we have outside there are not practical in our setup. So what we have done at MTRH is that we've come up with certain follow-up forms that will screen the patient for symptoms. So when they come for follow-up, they come, then there's certain things we screen for in terms of questions. And once we screen them, we can be able to now refer them for an appropriate test. Okay, so we cannot say definitively that there's this thing that you must do, unless it depends with one, the specific cancer, the type of treatment that you got, and the risks that we perceive that you have. So we have to see what cancer did you have, which treatment did you get, and from this treatment you can be able to say these are your risks. Thank you. I don't know if I've answered correctly. Solomon, you've gone mute.
Maybe I can read another question.
Okay.
Or it's a comment. Good presentation. For the data, do we also have data from private and faith-based facilities? I know there are facilities like Tenwek that do quite some work on cancer management, like cancer of the esophagus. The data from private facilities has not been very consistent. So we have some who report and some who don't report. But that's an area that we are trying to strengthen. But yes, the crucial thing is that they first of all need to be accredited by the National Cancer Institute. They're the ones who accredit these facilities. So it's also very important for our patients to be seen at facilities that have been accredited. There's a question about how do you find supportive and palliative care is integrated into survivorship for adults and children? Maybe I can even ask Eva. Eva, were you connected at any point to the palliative care team? And did they offer some support?
No. The support groups that I'm in, I just found them myself online, and then also now getting referrals and invitations from other survivors, but not through the hospital.
And I think there was a question, I don't know if you are willing to answer, about if the facility you visited was public or private.
It was a private facility.
Okay. Okay, so the question about, supportive and palliative care integrated into survivorship, the ideal situation is that palliative care should come in at diagnosis. Upon diagnosis, when you are referred to a cancer center, each cancer center needs to have a palliative care team. So after the oncologist has seen you, they've checked your biopsy results and they've confirmed that you actually have cancer, they should refer you to the palliative care team to now also come on board, because it's a multidisciplinary team. Okay, let me see another question. Solomon, are you back? There's a question about cancer cases are on the rise. Is there any research in this area to indicate what may be causing this? Dr. Susan, do you have any answer to this? I know we've all been wondering, but I'm not sure if there's a proper research that has started.
I would say there's research that is ongoing, especially I think in Cambridge. There's research trying to find out what might be, for instance, in the environment that might be causing a risk, an increased incidence of cancer. People are trying to look for answers that I can comfortably say.
Okay. So basically that's an area we are still looking into. Please say something about lifestyle and cancer. I think the biggest thing I'll say here is that about 40% of cancer is actually linked to lifestyle choices. So tobacco smoking, obesity, poor diet, they're all linked to cancer. So the 60% are those non-modifiable risk factors like family, age, which we can't do much about, but 40% is actually just our lifestyle. So it's something we need to check on. And this covers both the general public and even us as healthcare workers. I think sometimes we forget that we are also part of the public, so we also need to check ourselves. There's a question about, do you have any sponsors to children suffering from cancer? I have a child who has been treated for medulloblastoma for the past 1 year, and now it has recurred and they're not able to get funds for India treatment. Okay, I know there's support groups for children, like Hope for Cancer Kids. We've worked with them. They support children. They help them to get even NHIF cover. So maybe you can reach out to them. I believe they can be found online. Okay. Isaac is asking if there's a way we can mobilize resources, information, collaborations, and bring an end to this cancer menace once and for all. Isaac, that would be the ideal situation, but I don't think it's as easy as that. What we can aim for is to control it, you know, but ending it completely may not be realistic. And I think we are all scientists here, so we have to go with science. I don't know if this one, Dr. Susan, you can answer. What are the risk factors for osteogenic sarcoma in children? Dr. Susan?
Hello, pardon the question, sorry.
Yes, there's a question about what are the risk factors or the etiology of osteogenic sarcoma in pediatrics?
Okay,
If you're able
so
to answer.
I think there are several, but what we usually say with especially cancers of the children is that we don't have probably a lot of modifiable risk factors for pediatric oncologists. So of course, osteogenic sarcoma has a higher incidence of ages between 10 to 30. Usually, you'll find these are children who have a higher, like a taller height than children who are than their age, their normal age, and it's more common in males. You know, such things, race. Most of them you'll find it in Africans and Black Africans, for that matter. If a child had any radiation to the bones, if they had certain bone diseases at birth during their childhood, such as the Paget's disease of the bone. So such things will increase their risk, but most of them are actually non-modifiable, and therefore you cannot be able to modify them to be able to sort of prevent this child from getting osteosarcoma.
Okay.
Thank you. Maybe Dr. Jeffrida, you can also talk about the CPDs, the individuals who want to know.
No, that one we don't cover. That is for KNH cover.
Okay, thank you.
Yeah, they will address the CPD issues. I know we have a very few minutes before we close because we're to end at 3:30. Allow me to just pick a few questions that I can answer. There's a question about Kijabe Hospital being a treatment center. Yes, there's some cancer treatment happening at Kijabe Hospital, including for children. So that's the response. There's a question about how is our Kenya government supporting cancer patient treatment, or has the matter been left to partners, or is it a collaboration in terms of financing, logistics, supportive treatment? I don't know if you saw my presentation about the 11 cancer centers, public cancer centers that the government launched in 2019, the radiotherapy services at 3 of them, all these and more, and the drugs that are being supported to the patients. And even in terms of financing, the SHIF is also catering for oncology patients. So there's a lot that the government in general is doing, and also the Ministry of Health, and the partners come in. If you look at the cancer control strategy, it outlines clearly what we would want to do as a ministry. So the partners come in and see the strategy we have and where they can support us. That's the response. There's someone saying, I have a patient with chronic cough for years. Different doctors suspect acid reflux and treat symptoms. As we said, any recurring complaints needs to be investigated. So kindly let the patient be referred for proper diagnosis. Okay. All right. Maybe this can be the last question. What advice would you give to someone who has just completed their cancer treatment and is entering the survivorship phase. Eva, did you answer something close to that?
I'm not sure if I answered that one directly, but I would advise them to keep consistent with their reviews. Continue seeing your doctors. The visits get more spaced out as you go ahead. When I started, it was 3 months apart, and now I'm seeing the doctor 6 months apart. So I think eventually, I think I'll reach a point where I'll see them 1 year apart. So it's very important to continue seeing your doctor. And I think the one thing I talked about is knowing where you've come from and know where you're going, where you want to go, and just come up with a plan of how you want to, for lack of a better word, to live a new normal, because there'll be a few changes that you will need to make in your lifestyle, especially to make healthier choices. And find your tribe, find a support group, find someone or people that you can walk the journey with that have gone through similar, and you can share your experiences, comfort each other, console each other, and just generally be there for one another.
Thank you so much, all the panelists, for sharing with us the rich source of information that you've given us. Thank you, Eva, also for joining us and sharing with us the experience of walking through the cancer diagnosis, cancer treatment, and now in survivorship phase. I know this is an encouragement to all our patients and those of us who are coming to seek care. So thank you. I think the more information will be shared through our emails, and we keep to this channel for more webinars on the topic. Thank you so much, all.